Hi, everyone. I want to welcome you to our Lunch and Learn series for METAvivor. Thank you guys for attending. We are so thankful for each and every one of you. I see a lot of familiar names on here, and thanks, especially Kathleen. She's a patient reviewer for us for our research, and it's great to see you. First, I want to tell you a little bit about Rebecca, who's going to be talking about some personalized testing for metastatic breast cancer. And what's really come to our attention is that over the past few years, testing has become more and more critical in making your decisions for what your next treatment bridge or treatment option will be for metastatic breast cancer. And there's some testing that can kind of guide and help you and your oncologist make decisions, and that is critical. When I first started with METAvivor back in 2016, there were some options where there was a triumvirate approach, where there was a researcher and an oncologist and you, the individual patient, that worked with this team and looked at what different treatment options may be available to you. That cost about $40,000, and it was not covered by your insurance. And so it was unaffordable for most people. Well, this helps determine what the best approach is going to be moving forward. And then you'll get in the last two programs of our Lunch and Learn series, you're going to find out that there are some tests that could actually use certain samples from you to determine a good match for treatment in general. And that's really where we need to go, right? Because it takes the guesswork out of the decision making. So that's a little bit about what we're going to talk about and how important this testing is for you as an individual. Personalized healthcare is better healthcare. So let's get right into it. I'll tell you a little bit about Rebecca. Rebecca is our speaker today, Rebecca Waters. She's a PhD, also has her MBA. Rebecca, before her career at Natera, was an early career investigator awardee for METAvivor. She was a researcher that was funded for metastatic breast cancer research. She has a heart for metastatic breast cancer, and we're just so thrilled to have her with us today. She is the medical science liaison for Natera. Natera is a partner with METAvivor, and we are thrilled to have her aboard. She's going to talk today about a test that's used, it's a Natera branded test, but it's used and how it's used. She's going to talk a little bit about ctDNA, and then she's going to follow in her part 2 series with a second test and explain what those do and how they can benefit you. Logistically, if you don't think you can remember your question at the end of the program, go ahead and put it in the chat and we'll read those off when we finish. But let's wait till the end, because she may answer some of your questions during the presentation. Okay, and then we'll leave plenty of time for all of you to ask your questions. I know that there's many burning questions. I have many burning questions. So Rebecca, if you're ready, let's get started.
Yeah, of course. So thank you so much, Sonia, for the very nice introduction. As Sonia mentioned, I have previously worked with METAvivor, so your group is very special to me. And metastatic breast cancer is something that's an area of breast cancer that I have a lot of passion and motivation to work on. So it's a real honor to be here today and to be speaking with all of you. Okay, so we'll just go ahead and jump in. So here's the agenda of what I plan to present with you today. So I'm going to introduce Natera, what our company is, what we do, talk about circulating tumor DNA. Some of you may have heard about this before, but I'm going to go into and explain what it is. Then I'm going to explain what our Signatera test is. So this is the test that we use to track circulating tumor DNA. And then I'll share a personal story that one of our colleagues, an amazing woman, one of our actual sales specialists who lives in Florida, but is also living with metastatic breast cancer. So I'll share her personal story of how Signatera has helped her through her cancer journey. And then I'll go over how you can get Signatera, and then we'll discuss some frequently asked questions. Okay, so who is Natera? So as Sonia already mentioned, we're all about precision medicine, personalized approaches. And so Natera really got its start in the women's health space, looking at cell-free DNA. So looking at fetal chromosomal abnormality testing. So that expertise in cell-free DNA transitioned into looking at circulating tumor DNA. We also have, as I mentioned, we were in women's health, reproductive health. We've got our oncology division, and we also have a division in organ transplant.
Ooh.
We have 10 plus years of research and innovation, and we've performed over 4 million clinical tests. So one of the things about our Signatera test, which is in our oncology branch, what we designed this test really was to try to answer some of those top questions that you and your clinicians have. And I'm sure many of these will ring for a lot of you. I'm sure you thought this, you might be thinking this now. Am I cancer-free at the moment? Is my cancer coming back? Is my treatment working if you're in active treatment right now? And so that's really where our test is designed to look at molecular residual disease, which is really a tool for improving cancer management outcomes. And so you might be wondering, well, what is molecular residual disease? So this is the presence of very small traces or amounts of cancer in the blood. And those small amounts of what we're tracking are called circulating tumor DNA. So these are pieces of DNA that can be found in the blood. And so you might be wondering, well, how do those pieces of DNA get into the blood? So they're actually shed by cancer cells. So if you look at this little diagram here, imagine, this blue cluster here. This is maybe, the primary tumor. So these cells are growing, and within the cells, there's DNA. So as cells divide, die, they release the pieces of DNA into the bloodstream. These pieces of DNA can obviously go into other areas, but we can actually get a blood collection sample where we can then extract those DNA samples out, and we can sequence them, and we can look for mutations in that DNA that are representative of your tumor sample. And so the thing about molecular residual disease and the circulating tumor DNA, if left untreated, residual cancer cells are likely to cause cancer to come back. Then you will, often have a recurrence. And even following treatment, trace amounts of cancer can even go undetected on imaging. To date, we still have issues detecting micrometastases with just imaging. So ctDNA is a way that we can accurately measure this molecular residual disease, also ctDNA in the blood, and hopefully identify recurrence much earlier than other methods. And in addition to recurrence, identify if your treatment is working or not. Okay, so just to kind of clarify, cell-free DNA. So these are pieces of DNA that can be found in the blood. I mentioned tumor cells release these, and if it's from tumor cells, we call it circulating tumor DNA. But it's also important to note that healthy cells can also release DNA in the blood. And this will be important in a moment, and I'll describe to you why. And many of you may have also heard of circulating tumor cells. So these are cells that also, can enter the bloodstream, go elsewhere in the body. As you know, with metastatic disease, primary cells will break off, enter the bloodstream or lymphatic system, and go elsewhere, and those CTCs, those can be tracked as well, but that is a different test. So what we're looking at is only the circulating tumor DNA. So I just want to make that clear from the beginning that we are not testing CTCs, we are testing circulating tumor DNA. So those pieces of ctDNA that get shed from the cancer cells into the blood. So why is this important? So using this test, this is really a non-invasive tool for close disease monitoring. All we need for this are a piece of your tissue and the blood. So it is really a non-invasive test compared to other kinds of modalities. We can identify if there's any cancer remaining in your body, even after treatment. We can detect cancer recurrence even earlier than before than just with imaging or other serum biomarkers. And this can also give improved confidence in your scans when you're waiting, and it helps you know if your treatment is working. So the thing about this test and why we designed this custom test is because everybody's cancer is unique. And we like to say each person's cancer is as unique as their fingerprint. And so this is really why Signatera is unique, because our test, we design it specifically for your tumor and nobody else's. So how does that work? So we get a one-time sample of your tissue. It could either be from your biopsy, it could be from a resection, it could be from a recurrence. We take that tumor tissue, we sequence that. We also get a blood sample. And you're probably wondering, well, what are you doing with that initial blood sample? That blood sample, we actually use that to filter out normal DNA. Because as I mentioned earlier, why it was important, because normal cells will also shed DNA into the blood. So we filter that out because we want what is only specific to the tumor. And once we get that, we design a personalized assay that is just for you. So once this is designed, the doctor can't use this for anyone else. It is just to track your disease burden over time and nobody else's. And then after that, all you need are subsequent blood draws. So this is all about a trend. So this isn't a one and done test. This is something that you would get serially to measure the trend of your disease burden over time, if the disease is coming back, or if your tumor is responding or not. And so that's why we have this little graph here to kind of give you an idea of where you might start and where you might go. And then you and your physician can really kind of use this result in the shared decision-making process of what you want to do next. So our approach is very, very sensitive. So when you're looking for circulating tumor DNA, we like to liken it to maybe even looking for a needle in a haystack, right? Our test is ultra sensitive. We can detect one tumor cell amongst 10,000 normal cells. And so this really minimizes the false positives with this personalized and tumor-informed approach. So as you can see, Signatera can really be used across the entire cancer care continuum, the entire cancer journey for a patient. But for you today, I really want to talk about monitoring and surveillance. So some of you might already actively be in treatment. So this is a way to see how your ctDNA levels are rising or falling as you're on treatment to see how you might be responding. And then in the surveillance phase, maybe you're not on active treatment, but you might be concerned, is my cancer coming back? So in the surveillance phase, this is where you could get tests over time to see if there's any ctDNA present or not. Okay. So really some of the key takeaways from our test that I want to point out to you, it's really a personalized test. We like to call it bespoke or custom because it is designed, again, just for your tumor and nobody else's. It helps detect recurrence, also treatment response monitoring. As I mentioned, it's custom built. So it is built off of unique mutation signatures of your tumor. And we actually have data across multiple solid tumor types, obviously including breast. And really, you can use this alongside other biomarkers and imaging. We're not saying that, you would throw out imaging and everything else. This is really another tool for your providers to have in their toolbox to help get a better overall picture of what is going on with you and your disease state globally. And, it can be used to determine if there are any signs of cancer remaining in your body after initial treatment, whether additional therapy is working, and if your cancer is recurring. And so ultimately, as I mentioned, this is really about, having a more informed discussion with your doctor regarding your personal treatment journey. So I really want to share this story. So this is an amazing woman. This is Angela Devine, and she is one of my colleagues at Natera. She is actually one of our sales specialists. She's located in Florida. Angela is an amazing woman. Angela is also living with metastatic disease. And this is her personal story that she is incredibly brave to share with everyone because in hopes that she might be able to help someone else and also give you an idea of how Signatera could be used in your particular case. So just a little bit of background about Angela and why she's so passionate about this test and why it's helped her. I think these pictures explain it all. her beautiful family, her dogs, and you know how this is just kind of give you a snapshot of Angela and her personal life. And so this is her story and what she wanted to share with everyone. So she is 47 years old, married, has 2 girls. As I mentioned, she's one of my colleagues working at Natera. She actually asked her oncologist for Signatera back in July 2021, because at this particular point in time, she was already deemed metastatic, but she had been treated. And at this point on scans, everything was appearing negative. But then she started to have symptoms. She presented with breast pain. Her markers looked normal. Her ultrasounds, breast MRI were all normal. Then one night, she was actually at a dinner program presenting on Signatera, and she felt a bump on her head. And, you know, it took months, but she ended up asking her oncologist to submit for Signatera again for another blood draw. And when they did that, her CT scan, so this also prompted her oncologist to order a scan along with that blood draw. And what it actually came back was suspicious, and her PET actually showed numerous lesions on several bones in her lymph nodes. So in January of this year, she started targeted therapy and she had radiation. Then in March, it showed that her lesions had decreased by 50% or more. So just to kind of give you an example of what a result would look like, there are 2 components. The first is just a quick snapshot. And this is the result that your provider would get. It says, are you positive or negative for ctDNA? And then down below, these are actually the results. And we put all the results on one graph to make it as easy as possible for your provider, so they can actually get an idea of the trend and the burden of disease over time and what's happening in your particular case. If you look at this graph on the scale here, this is the Y scale. This is actually the amount of ctDNA that has been detected in the blood. And then on the X-axis here, these are all the different time points that were collected. And so this is Angela's personal test that she is given permission to share. And if you look, you can see there's a closed-in circle here. This indicates that she was initially positive. And you can see her disease level rapidly increased. And this is around the same time when she started to find that bump on her head. And then they ordered the PET scan after they saw her test results for ctDNA were elevated. And then, as you can see, she went on to receive her radiation and targeted therapy. As you see, her ctDNA levels start to trend downward as she receives the therapy. And then over time, you see the circles start to become open. So this indicates that she is negative. And if you look down below at the chart, there are actually the amounts of ctDNA that correspond to each of these time points. And I'm pleased to say now, since actually June of this year, she's had several more tests and they have all come back negative. So really, it's kind of given her peace of mind to know what is happening in real time as she's experiencing these symptoms, as she's going through treatment. And now she knows at this point, she's negative for ctDNA. And so this, along with her scans, helps give her peace of mind that, you know, at this point, she's feeling okay. So if any of this interested you and you're thinking, well, I want to know more, now what do I do? So this is something that you would need to work with your provider. So this has to be ordered through your provider. Unfortunately, patients cannot directly order this. This is something that a medical professional has to order. And so how does this work? So when your provider gets connected with us, we actually have a patient coordinator team that can call to discuss Signatera testing and billing. And if your provider is managing your blood draw, they will connect with you about the blood draw. We also have mobile phlebotomy available, which I'll talk about in a moment. But a Signatera blood draw kit will be shipped to you if you opt for mobile phlebotomy. If not, the kit will be in your doctor's office when you go in for your blood draw or your checkup. And then afterwards, your sample gets shipped to Natera, and we run the test. And turnaround time for the initial building of the assay, because if you remember, I mentioned we need to have a piece of tumor tissue to build the test off because it is tumor informed. So that turnaround time is around 3 to 4 weeks. And then the blood draws after that, going forward, turnaround time is roughly 1 week. And then once your doctor receives the results, like that graph I just showed you. They'll discuss the results with you, and then you can, go through your shared decision-making process together of how you want to approach your treatment in the future. So just to kind of let you know, we have blood draw services at your convenience. So again, it can be done in your doctor's clinic, or it could be done in the comfort of your own home, because we have this mobile phlebotomy service. And I know patients that tend to live in rural areas appreciate that option, because it's not always easy for them to get to the clinic in order to do these sorts of things. Okay. So just to kind of briefly go over these frequently asked questions, because I know maybe some of you might be thinking this already. Again, how is the test performed? It's a one-time analysis of both blood and tissue to determine your unique set of mutations. The test is custom built. Again, it is personalized only for you and your tumor. And then after that, all we need are just subsequent blood draws. And we use those to detect the presence or absence of circulating tumor DNA in the blood. And it gets ordered as part of your routine follow-up. And so I kind of already went through turnaround times. Again, the initial build of the test takes about 3 to 4 weeks. Then after that, every subsequent blood draw thereafter is about a 1 week turnaround time. So you might be wondering, well, what do these results mean? So I just gave you an example of Angela's test results. So if the test comes back positive, this does mean that you might have a higher risk for your cancer returning. If it's negative, this means that you are at the moment more likely to remain cancer-free or low level of disease. If the ctDNA starts to increase, as you could see in that graph, you could see the line started to trend upwards. This might mean that your cancer might be progressing, or that you might not be, your tumor might not be responding to treatment. And then the opposite, if the ctDNA is decreasing, this means that perhaps it's improving and your tumor is responding to treatment. And so you might be wondering, all right, here's the big question: how much does Signatera cost? So we understand this whole process can be really confusing. Insurance doesn't make it any easier. So at this particular point in time, we welcome all plans, and we will work with them and you to make sure cost is no barrier. We also have an affordable cash pay rate for patients who do not wish to use insurance. And so you're wondering, well, how do I order? So this is something you'll want to talk with your doctor about. And I mentioned to Sonia earlier, I actually have a patient discussion guide that I'm going to share with her that she's going to send out to all of you as participants on this call today for you to read about, and also the questions for you to bring this up with your provider. And then you and your provider can determine if this is the right test for you. Okay. And one of the other things I just wanted to put up there, if you'd like to know more or read about it more yourself, one thing I know working with metastatic patients in the past and advocates, all of you are extremely well read on this topic. And I know a lot of you love to do your own research, which I really commend. So I want to just share this link here. So if you want to look into it, we have a whole patient designed website for you to go in and learn more about our test. As I mentioned, you really want to talk with your doctor about this, because the test needs to be ordered from your provider, and they will help you determine if this is right for you. And if you have any personal questions, feel free to reach out. We actually have this specific email address, oncologypc@natera.com. This is specifically for patients. So you can reach out at any time with questions to that email. And I will also share this with Sonia as well, along with that patient discussion guide for all of you that are attending the call today. Okay, so one thing that we like to talk about is really Natera is changing the management of disease worldwide, hopefully with just a simple blood draw. We really are a disruptive technology, disruptive in a good way, trying to push the diagnostic space further so that we can really move towards precision medicine for everyone, especially in the metastatic setting. Okay. So I will conclude there, and I'd be happy to take any questions. One thing I did want to mention. So I'm not a medical professional, so I personally cannot discuss with you your treatment options or anything like that. So I just want to let you know that disclaimer at the beginning. but happy to take any questions about our test.
Thank you so much, Rebecca. We appreciate it. We're going to start with the chat, but before I do that, let me introduce a couple of people.
Yeah.
Jamie Schwarzbeck from Natera is also on the call. She's been wonderful to work with. She's a colleague of Rebecca's. And then also we have two board members, Sheila Gaudreau, who is on the call, and Janice Cowden. And they are intimately familiar with what we're doing here in the Lunch and Learn series. So if you need a peer opinion about anything, those two can help. And then if you know anybody who is interested, or if you prefer someone who can speak Spanish, Sheila can do that as well. So just let us know how we can help you the best way that we can. So our first question in chat is, how is this at detecting brain mets? Inflammatory breast cancer is always mets, diagnosed 3 or 4 always.
So that's a great question. At this particular point in time, we are not detecting anything in brain mets because of the blood-brain barrier. I know there's discussion maybe in the future of looking at cerebrospinal fluid, but unfortunately at this particular point in time, our test is not there. And then you mentioned inflammatory breast. I do know that we have tested on inflammatory breast before, and actually some particular providers that are leaders in this field have sent tests in for inflammatory breast. So we do have that. And actually we've tested across all subtypes. So I didn't get to mention that, but hormone receptor positive, HER2 positive, triple negative. We've tested across all subtypes, just in case that's anyone else's question. Okay.
We also have Kathleen, who, I'm sorry, Juanita, who said, is this covered by insurance? We talked a little bit about that. Rebecca let you know that. And then also Jamie in the chat said that there's also a patient program, a patient assistance program. So you can reach out for more information about that. Kathleen asked, how is this different from other blood biopsies?
That is a great question. So as I mentioned, we need that tumor tissue because it's tumor informed. Other blood biopsies at the moment that are approved only work off of blood. And if you remember earlier, I told you that normal cells also shed DNA into the blood. And so by us collecting the tumor, we're finding what is only specific to that tumor. Because when you're trying to track disease, you don't want all of this background noise from your normal cells or other things that are in the blood. So because our test is tumor informed, that's what makes our test stand apart and makes it more specific.
Okay, how long does it take to get results? I think you talked about that, but would you like to mention that again?
Yeah, absolutely. So because, as I just mentioned, our test is tumor informed, it does take a little bit longer because we are, performing in-depth sequencing on that, right? And so for the initial build of the test, it's about 3 to 4 weeks. But then after that, as your provider continues to serial monitor you, that's turnaround time's about 1 week for results.
Does Signatera correlate with CA antigen?
That's a great question. So we've actually, we've got our start first in colorectal cancer. And we actually did some correlations between our ctDNA and CEA. And we actually found our ctDNA test was more sensitive than CEA. And we've also compared with other biomarkers, in particular CA15-3, which often gets ordered in the breast space. You also heard of probably 27, 29. We found that, again, our ctDNA is much more sensitive at predicting recurrence compared to those serum biomarkers. One of the other things about those serum biomarkers like CEA, CA15-3, 27, 29, or even CA125, like they use in ovarian cancer, they're not always expressed in every patient's tumor, right? So you're not going to find that. And sometimes inflammation or other things can affect those levels. And we've actually found our test is more sensitive and specific than those. But that was a really good question.
Can initial biopsy be used, or is a new biopsy needed?
Yes, we can absolutely build this off of your initial biopsy. One of the things when we talk with your provider, I always like to mention, we just need a minimum of 20% tumor content. So that's how many tumor cells are present in that sample. And so our company, we have a team that works with your provider's pathology department to help select out the best sample to send in.
Does Signatera accuracy depend on breast cancer subtype?
Accuracy. So no, you know, the sensitivity and specificity doesn't change across tumor subtypes as far as we've seen. I will say that certain subtypes shed at different rates. So obviously you're more aggressive triple negative. We see higher levels of ctDNA for those tumors than we do for hormone receptor positive tumors. So if we just, you know, make a comparison here from what we've seen, if you look at something that is, you know, a stage 1 hormone receptor positive, low oncotype score, those tumors don't shed very much at all. But if you compare that to something like a triple negative or HER2 positive, or even hormone receptor positive, what we call high risk, so maybe high oncotype score, high mammaprint score, those ones shed more. So it's more about shed rate versus the specificity.
Janice put in the chat, I had a Signatera test ordered by my oncologist in January, had blood drawn, then was told that there wasn't sufficient tissue bank to create the tissue companion assay. Key learning from that was that there's a required amount of tissue needed. I was told that my original biopsy specimen could be used from 2011. However, the lab had already discarded that. I'm hopeful that a tumor agnostic test will be developed in the near future. Is there any plans for that, Rebecca?
Yeah, so that's great question. And as I mentioned earlier, we do need a minimum of 20% tumor content. That's just so that we have enough material so that we can really accurately find those variants that we're tracking over time as we develop kind of like that fingerprint signature for you. Unfortunately, this time we do not have a tissue agnostic test. I do know that there maybe are plans to probably go for that in the future, especially for in your situation. I'm very sorry to hear that, you know, your institution discarded your block. I do know, or your sample. I do know over time some institutions have a hold on how long they'll keep things, or they might ship them off to other places for storage. So we do know that that is an issue. And, you know, that is something that our R&D team is aware of, and hopefully, you know, we might have an option for you in the future. So definitely stay tuned.
If you've had multiple solid cancers that you want to follow, could one Signatera test follow that? Or would you need multiple tests, one test for each cancer?
Yeah, wow, that's another really good question. You all ask excellent questions. So our test, because it is so specific, when you design that, let's use an example, right? Let's say a woman has a tumor in both breasts. If we design it for the right breast, the tumor in the right breast, that test will only work on tracking that tumor in the right breast. That's how specific this is. For the other tumor, we would have to design a completely different test. Now, at this particular point in time, the way that logistically things are set up, we can only track one tumor. However, I'm told in the new year that changes are coming where hopefully we will be able to track multiple tumors in a patient over time. So definitely stay tuned for that as well. But wow, that was a really, really great question.
If there have been 2 biopsies with different subtypes, would both samples be used?
With different subtypes. So biopsies from the same tumor? Is that what you mean?
Juanita, this is you. Can you clarify?
The first biopsy was my initial one in 2018, and then I had a recurrence last year in the original breast. When I had a mastectomy and a biopsy, that it was determined to be a different subtype than the first biopsy.
Yeah, so that's a great question, Juanita. So obviously this would ultimately be up to your provider, but I would think they'd want to use the most recent one, especially because if that's that's the new tumor, that's probably what they would want to build it off of and not the original.
Okay, but I'm still treating for both subtypes. So is there a space that Signatera would use both?
Yeah, so this is where ultimately, based on the subtype, your provider would make a decision to build it off of maybe the more aggressive one, the more aggressive subtype.
Okay.
And that's what we've seen providers do in the past.
Okay.
Mhm.
Since I'm talking,
Yeah.
when did this test start? It started for other cancers before it became breast cancer, right?
Yeah,
Okay.
yes. So we've been out for about 3 years now.
Okay. And when did it move into the breast cancer space?
So breast cancer space, I would say we've had, a couple research papers that we've published since 2019, but we really launched in breast last year.
Okay.
Okay.
Thank you, Juanita, for sharing. You have a very unique situation there.
Mhm.
I was, this is from Sue. I was unable to log in because of Eventbrite. Okay. Will we get a copy of the recording? We will make a copy of the recording available to everyone after the Lunch and Learn series has completed. You discussed this to some extent, but I have asked, and my provider is inalterably opposed to this type of testing. She says it is not valuable in determining treatment, not actionable, not standard of care. Is there a workaround for this? Thanks for forwarding test info. Maybe I can make progress on persuading her.
Yeah. So that question, unfortunately, that's not a unique one. We do run into this. So my role as a medical science liaison, I'm really the one who speaks with providers for a company. And I'll tell you, there are some out there that, haven't necessarily learned about the test, or they have learned about it, but, it's so new, right? If you all think about when tests like Oncotype DX first came out, right? There was a lot of hesitancy and people were nervous because it's new. So really what we try to do is combat that with education and help them understand how this could help, help them and help their patients. So if you have a provider, if you'd like to pass on their contact information to Sonia, she could share that with me. So I am one of 6 breast-specific MSLs across the country. So we will find out where your provider is, and we can have me, if they're in my area, I cover the Northeast, or one of my colleagues' areas, we can reach out to them directly and see if they want to have a conversation with us. Because that's one of the things that we do. We will either over Zoom or in-person meetings go to them, explain the test, how it works, and we also will go over all of our research. We go through all of our data, all of our papers, everything we have in metastatic, surveillance, neoadjuvant. We really try our best to help educate them and let them know what resources are available. So in regards to a workaround, I'm sorry, I don't really have anything other than that. Maybe seeking a second opinion from another provider who might want to know more about this or try it. That would be my suggestion. And also, as I mentioned, if you want to pass on their contact info to Sonia, she could get it to me, and we'll try to get someone on our medical affairs team to reach out to them directly. So that way, maybe we could get the conversation going or help you get the conversation going. And also that patient discussion guide I mentioned, I'll be sharing with Sonia. So all of you can maybe have that material in hand to hopefully continue that discussion with your provider.
Sorry, I was on mute. That question came from Caroline Coram. She's a wonderful volunteer for METAvivor, and we just appreciate her so much.
Yeah, great, thank you, Caroline.
Chris Creighton, that she said, good question. Lauren Wolfes, did these results actually help with determining treatment-specific drugs that would be beneficial for your specific type of cancer?
Yeah, so that's Great question. So this is a different kind of test. Actually, what I'll be talking about next week is a panel to look at clinically actionable genes, clinically actionable meaning there might be FDA approved therapies or clinical trials that your provider could put you on. So that's a different test. That's called Altera. So we'll be discussing that next week. This Signatera test does not tell your provider a specific therapy to try for you. It's more about tracking that burden of disease over time and getting treatment response monitoring. How are you responding to your treatment? So a little bit different of a concept.
And over the next 2 weeks, our next 2 sessions, we'll be talking about matching treatment options. There's some specifics where that's concerned, because again, we're talking cutting edge. This is the newest and latest test. There are going to be late adopters. We know that, but we need to make sure that we're staying on that cutting edge for each and every one of you. Carol asked, when was the test first available? We talked about that already. Can you discuss accuracy in the setting of minimal bone met only disease?
What?
And that is from Caroline McIntyre.
Caroline, I really appreciate that question, because when I was a researcher, what I specifically studied was bone metastases. And I will tell you, unfortunately, at this point, we are not working in bone metastasis samples. I'm hopeful that eventually we'll get to that in the future, because they know once they get there to let me know, because that's my area of interest and expertise. But unfortunately, at this time, we can't do bone biopsy samples.
Okay, Linda, can Signatera replace tumor markers? And Linda, we are so glad that you're on today. We've missed you.
So Linda, thank you for that question. At this particular point in time, our data shows that our test outperforms serum biomarkers, like I mentioned earlier, CAA, CA125, 15-3, 27-29. However, we're not saying.
Sorry, Rebecca. I'm sorry.
Yeah.
This is me, Andra.
Yeah.
I am under heavy meds right now. I really want to continue, but I have to. No, it's okay. It's fine. I will. The recording will be on. I'm sorry. I'm a little confused right now.
That's
but
okay. Yeah.
I am very grateful for this, and I'm gonna be sleeping now, but I know that the recording will be put somewhere, so I'll get all of that then. Thank you so much for everything. I'm just gonna go sleep
Thank
right
you,
now.
Leandra.
Yeah, thank
I'm
you.
so grateful for all of you, so many information. So I'm really grateful, and I will continue, whenever is possible, I will continue. Thank you so much for everything. I'm just gonna go sleep right now, and I will keep in touch with all of you. Thank you so much. Have a great afternoon.
Thank you, and I hope you get some rest. Thank you so much.
I will. Thank you so much for everything. Have a good day.
Bye, baby. Care.
Bye-bye, Hans. Let me see how to stop this.
You were talking about the tumor markers.
Yes, yeah.
Can it replace tumor markers?
Yeah. So at this point, we are outperforming them, but we're not saying that we should replace anything at the moment, right? As more clinical trials and data become available, maybe that might become something in the future. But at this point in time, we just say that, we're really another tool in the toolbox for your provider and for you.
Carol says, can your disease change so that the initial tissue may be a long time ago, because Mets was diagnosed 14 years ago? Is the tissue still good, or can the cancer change?
So great question. So yeah, so I know a lot of you are probably already aware, as you get treatment over time, you end up getting sometimes acquired mutations. The tumor can evolve, different clones can go elsewhere in the body. So that's one of the things about Signatera. Because of how we select those variants, we are looking for those mutations that are present. If you imagine like a tree, we call it phylogenetic trees, or just imagine a regular tree. We are looking for those tumors, those mutations that are present in the trunk, right? So those are the ones that are there at the very beginning, and they're going to be with that tumor throughout the life of that tumor, regardless of where it goes and evolves. So that's really what's kind of special about this test. And those variants that we choose that are present at that very beginning part, the truncal mutations, as we call them, the truncal clonal, those are really less susceptible to treatment selection pressures.
What is accuracy of Signatera as tumor mutates? Can you explain scientifically, without violating intellectual property rules, what is in the ctDNA that does not depend on changes in cancer mutation as we've done?
Well,
and that's from Melissa Chandler.
Melissa, if I knew, I wish I could tell you. So the algorithm and how they choose those variants, it's actually based on 16 clonal variants from the beginning. How they choose that, it's proprietary. They don't even tell me. So unfortunately, that's kind of like the secret sauce, I guess, of how the assay is built. So unfortunately, I'm unable to share that exact algorithm and the method of how they choose those variants. But all I can tell you is those are those clonal truncal mutations that are present at the tumor at the very beginning.
Okay, Susan Harano says, how much tissue is required? I've had tests sent back before since they require 20% tissue, and a similar test had only 5% and it was not readable.
Yeah, so that's really, that's the thing. We do need that 20% minimum content, just so that we're making sure we're getting the right amount of variants, because we have these quality control cutoffs that we have to meet so that we know that we're building you the best test possible. We don't want to build anything subpar with variants that we know are not good. So we really need that minimum content. Now, I've seen in the past when this happens, we can go back to the pathology partner and your provider to see if maybe there might be other tissue blocks or other biopsies or things that we could use. And sometimes there are additional blocks, so they'll send new ones in and those will have more. But that's something where if they haven't already checked into that for you, maybe see if they can do that. See if they can get an additional block from that sample, because when they take a resection, sometimes it's large enough that there will be multiple samples. And so that's really where we can work with the pathology partners of your provider to find the best one.
Patricia, this is from Patricia. If your cancer mutates, does it only pick up your original tumor DNA, or can it pick up new mutations?
So it does not pick up new mutations, but as I mentioned, because of our algorithm and how it's built, those variants that we chose at the beginning, those are going to stay with that tumor over time. So even if your tumor develops acquired mutations due to treatment pressure, it's not going to affect these variants. These variants are not clinically actionable genes or anything like that. So they are not going to be affected by those treatments or those new mutations popping up over time.
Janice says, I've biopsy tissue from 2016, but not enough according to pathology at Signatera. Fortunately or unfortunately, I've been NED for 6+ years, so no new tissue is available. Is there anything you can do at that point? Or is maybe this not the test for her and Altera's the test?
Yeah. So with that, and with Altera, we still need tissue as well. So at this point in time, well, first off, I'm really happy to hear that you are NED for 6 years. That's wonderful news. This is, like that one question earlier where they mentioned, do you have a blood only test? So unfortunately, we do need tissue to be built off of. So at this point in time, this probably would not be the best test for you. But in the future, you know, I mentioned if we do get into blood only, that might be an option for you.
Sorry, I was muted.
That's okay.
Carol Paris Stephens. I have bone mets and recently liver lesions. Would I need a separate tissue for the liver?
So, like I mentioned earlier, unfortunately, we can't work off bone met samples at the moment. But if the liver is, if your provider is able to biopsy that, or if they already have a biopsy for that, yes, we could build off of that. Again, being that there's a minimum 20% tumor content.
Tracy Gudger, sorry, Tracy. I have bone mets with a spot on my liver. The biopsy on the liver did not yield anything to analyze. So would I need to see if my initial bone biopsy is still available?
So, unfortunately, again, because we can't use the bone biopsy, if maybe your initial primary tumor sample might be available, you could look into that. If they have your biopsy, or if you went on to have surgery after neoadjuvant, if there's some material left from the resection, we could always build it off of that.
Chris Creighton says, I would like to give you my provider's contact info. How can I do that? Do you want to just reiterate how you want them to contact? Because I imagine there's going to be a lot of contact.
Yeah, so if you want to share your provider's information and where they're located, because then that helps me figure out if they're in my territory or one of my colleagues' territories. If you want to, Sonia, is it okay if they share that info with you, or is there someone else on your board you'd like them to, or?
Absolutely, that you can reach out to Sonia at METAvivor.org, and Sonia is spelled SONYA at METAvivor.org. And we'll just forward all of that information over to Rebecca.
Mm-hmm. Thank you. Yeah, and then that way we can try to reach out to your providers and get some discussion going with them.
Linda Weatherby, we love you, Linda. This is such valuable info. Thank you, METAvivor and Natera. Paula J had to drop off. Let's see. Okay. It sounds like you can't test bone samples. Do you still find it helpful to test the sample from the tumor from the breast, even though it's spread to other places?
Yes, absolutely. Because we've seen instances of this when we've built it off the primary, we were still able to use it in the recurrent setting later on if the patient's tumor turned metastatic. So yes, you can, because like I mentioned, we choose those clonal truncal mutations from the beginning. So those are going to be present with those tumor cells throughout that cancer's lifespan, basically.
Carol says, in 2004, I was diagnosed with estrogen positive. 14 years later, it's mets to bone and now liver. So which tissue do you use? Just the breast from 2004, or do you need one from the liver? So
we can build it off of either. Sometimes, depending on where they are in the liver, it might not be able to be safely biopsied, right? So maybe your provider has not biopsied that. I do know that, it's becoming more and more common practice to biopsy the metastatic tumor sites, because I'm sure many of you are aware, there's this thing called receptor discordance. So something starts out as a certain subtype and then it changes. So I know that biopsying those metastatic sites is becoming much more common. It should be, hopefully, everywhere. So what we would say is, and I think this is the question we had earlier, maybe it was Juanita mentioned, well, my new recurrence is a different subtype. So what we would say is, if you have that biopsy result from the metastatic, and they know that that one might be more aggressive than what the original primary tumor is, maybe the provider will want to build it off of that. However, if it's the same as the original primary tumor, you could build it off of that as well. And really what it will come down to too is how much tissue is available for either sample. Because again, just getting back to that point, we do really need a minimum of 20% tumor content.
So that's all of the questions in the chat. If you have a question that you didn't put into the chat, please raise your hand and we'll take those one at a time. We have about 5 minutes left. We do have one more in the chat.
Yeah.
Tammy McLean, I'm concerned I won't have the 20% tissue from original tumor. I've also had lymph node biopsy. Can this be used?
Yes. Yeah. They could try to build it off of the lymph node biopsy. Yes.
Excellent. I'm looking for any raised hands. And I don't think that we have anybody else that with questions. I want to tell you all, thank you so much for spending your lunch with us today. Thank you, Rebecca, for all your knowledge, and thank you, Jamie, for joining us on today's call. Rebecca's going to be an old friend next week.
Yeah.
So join us for Altera, and then our last program in the series is Trevera. And when you talk about new tests, we're talking about brand new tests when we get to that. So, but there's all very exciting cutting edge information that we need to know, right? So if you have any questions, please reach out to us. We will have the recording posted. Rebecca has a blog that will be put up on our blog as well that talks about this. So if you need to refresh yourself or if you want to share it with your provider. My address, again, email address is sonya@metavivor.org. So thank you guys so much for joining, and we will see you next Wednesday. Thanks, Rebecca.
Thank you. Thank you all so much. And thank you for the amazing questions. I always get the best questions from the patient advocate groups. So thank you so much for your time.
Have a good day.
Thanks, you too.